Hey, well, welcome everyone. I'm here today with one of my favourite plastic surgeons in the whole entire world, which is Dr. Damian Marucci. I love Dr. Marucci, apart from the fact that he's great. I love him because Dr. Marucci was actually our very, very first client in Plastic Surgery Hub. So, yay! So thanks for joining us. Thanks for joining us, Dr. Marucci.
Thanks very much for having me. Please call me Damian.
Okay, all right, awesome.
Yeah, thanks.
Awesome. I thought I'd be formal for the podcast, but I'm so happy to call you.
No, of course.
Yeah, great.
Thank you, Ms. Hammond. Thank you. Yes.
Well, I'm really excited because today we're going to have a chat about breast reconstruction because I know that you do so many of them.
Yes.
I've actually got a bit of a list of questions here, so I hope you don't mind. And
no, hit me. Fire away.
And if there's anything more that you want to add, feel free to just go for it.
Of course.
The more into the better. So,
no worries.
I know you do lots of reconstructions, but how often do you do a reconstruction at the same time as removing breast implants?
Yeah, in terms of reconstruction after breast cancer, the timing, there are essentially two options. It can either occur at the same time of the mastectomy, that's called an immediate reconstruction, or it can occur after the patient has finished having all their treatment, like they've finished their surgery, their radiotherapy, their chemotherapy, and then they come back and have their reconstruction. Probably nowadays, well, there's been a big change over the last 10 years, and probably most of the reconstruction I do nowadays is at the time of the mastectomy. So I work very closely with the breast surgeons who are in the area. We both see the patients separately. You need to pick the patient though. That's not applicable to every patient, but certainly a very high proportion of patients can have an immediate reconstruction. Mm-hmm. In terms of how it's actually done, it's different for different patients. Probably the majority of patients who have an immediate reconstruction, it's a reconstruction with an implant. So the breast surgeon comes along, they remove the breast cancer and the rest of the breast tissue. Sometimes the nipple is also removed, unfortunately. Other times the nipple can be preserved. I will then come along and lift up the muscle on the chest wall. Sometimes I'll use a sheet in order to hold everything in the right position. And then I'll take a breast implant like this one here, and then I'll put this implant underneath the muscle and I'll close the skin over the top. There's a drain on top and a drain underneath, close the wound, and that's it. So this is a one and it's done technique. So it's called direct to implant reconstruction, and it's a single stage procedure. There are many considerations in terms of whether someone is suitable to have an immediate reconstruction. Mm-hmm. If someone needs, for example, radiotherapy soon after their surgery because they have particularly aggressive disease, it might be best not to perform a reconstruction at the time, but rather wait until the patient's finished having all their other treatments and then perform a reconstruction so it can deal with the irradiated tissue. Just to take a step back though, in terms of breast reconstruction overall, the thing to remember is there are essentially only three ways to reconstruct a breast. We can either use an implant, or we can use the patient's own tissue, or we can use a combination of the two. Again, those three different groups can be used either at the time of the mastectomy, so an immediate reconstruction. So say, for example, someone's suitable to have a tram flap. That's where we take skin, fat and muscle from the tummy and move that up onto the chest wall in order to reconstruct a breast without the use of an implant. If they're suitable to have that at the time of the mastectomy, that can be done at the same time. Other patients might not be suitable or might not want that kind of surgery, and instead we can look to either put in an implant at the time or even do, say, latissimus dorsi flap with an implant at the time. So just back to the original question, probably over half of the reconstructions I'm doing now are immediate reconstructions, and the majority of those are just directly with an implant.
Okay, so depending on how aggressive the cancer is, depends on which, so it's an individual thing. Yeah,
look, the key thing about breast cancer is that patients with breast cancer are treated as part of a team. It's not just the breast surgeon, it's not just the oncologist, it's not just the radiation oncologist or the breast care nurses, it is a team, including the reconstructive surgeon. So it's important that all members of the team have input, and it's good in a way because it means that you know that everyone brings their expertise. So the radiation oncologist will come along and will say, oh, look, you know, I know you are really keen to get on and do this operation, but I really would like to do radiotherapy sooner rather than later, so you need to think about that. So it's important that the team communicates well and is harmonious, and that everyone is focused on what is in the best interests of the patient and in treating their underlying cancer. So if the team decides that it's fine for a patient to undergo a reconstruction at the time of surgery, then that's probably the way to go.
Okay, all right. So it's a decision that's made as part of the team, and
exactly.
All right. I actually have a friend who just recently had it done, and she had it in a 2-step process because it was very aggressive. Yeah.
Yes. Well, the thing about it is that in terms of even just using an implant, a lot of times because skin often has to be removed in addition to removing the breast tissue. So if you remove a lot of skin from the breast, you can't simply just put an implant straight back in because there's just not enough room. You can't close the skin over the top. So what we do in that situation is a 2-stage type of reconstruction using an implant. At the first stage, we'll put in this. This is called a tissue expander. It's basically an empty implant, and it's got this special port here. The thing about this port is you've got this magnet finder that can show you where the port is. So, for example, say this is underneath the skin. If that's underneath the skin, this will point to where that port is. You can put a needle into the port and put fluid into the expander, and then slowly over a period of weeks, so you'll see the patient every 1 to 2 weeks, over a period of, it depends on how much fluid you need to put in, you'll slowly fill the expander, and it stretches the overlying skin and creates new skin in a sense. And then once you get to the volume you want, then you can remove the expander and put in an implant. So that's a 2-stage implant-based breast reconstruction. In terms of going just directly to the implant, we just put the implant in. That's something that has only really gotten a new lease of life in the last probably 2 or 3 years due to improved technology that we have around holding the implant in position using something called acellular dermal matrix, which is a sheet that you can suture to hold the implant in position and cover part of the implant. But that's really only sort of gained traction, well, especially in the last probably 4 or 5 years. Before that, almost all implant-based reconstruction was with the first stage where the expander went in, and then the second stage where the implant went in. And so if you look in the literature, there are a lot of senior surgeons from all around the world, but particularly in the United States, who have extensive experience and who have fantastic results, and all they do are 2-stage reconstructions. Whereas I do my best whenever I can just to go for a 1-stage direct-to-implant reconstruction.
Okay, and with the expander, what do you actually fill it with? Is it
saline, just salty water?
Okay.
So at the time of surgery, we'll put a little bit of fluid in there. I mean, we'll put as much as we can to sort of start things off, but not so much that it puts tension on the wound. Then I let everything settle down. I normally wait about 2 to 3 weeks, and then I'll see the patient just here in my office, and then I just put a needle straight through the skin into the expander, and normally the skin's pretty numb because the patient's had a mastectomy, and then you can slowly start to fill it. I put in as much as I can every time I see the patient, and I'm limited by when the patient says to me, oh, that's starting to feel a little bit tight, then I stop. I keep track of how much fluid I put in, because at the end of it, the patient will look down and say, oh, look, I'm actually happy with this volume. And I'll say, okay, well, we're at 400 mils. I'll actually overexpand a little bit, but then I know I'll need a 400 mil implant when I come to exchange the expander for the implant. That second procedure does involve a second general anaesthetic. It also does involve a drain, which is a bit of a hassle, but it's a pretty straightforward kind of thing.
And what can the time frame be like from
between the two?
Yes.
Yeah, no, that's probably the most common question I get. And the answer is it depends. Say I put in 100 mils at the time and we need to get to 400 mils, and then I see you, I put in 25 mils and you say, oh, that's feeling a bit tight. And then a week later, 25 mils, oh, that's feeling a bit tight. You can see it's going to take me a couple of months before we're anywhere near the volume. Where there are some patients where you get 400 mils, I put 100 mils on the day, I put 100 mils at 2 weeks, 100 mils at 3 weeks, 100 mils at 4 weeks,
right,
and we're there.
Okay.
As I say, I do like to overfill by at least 10%, and I like to let everything settle for at least 2 weeks.
Okay.
But the thing about it is that with the expander, you can still get back to doing everything you want to do. You can do exercise, you can travel, all that kind of stuff. So there's no huge rush from that point of view. It's not like as if, look, if we don't have the expander exchanged for an implant by a set period of time, that something bad happens. The expander can just stay in there, for as long as you want. The expander, when it's filled with fluid, doesn't feel as nice or as natural or look as nice as an implant does. It feels quite firm and solid. One of my patients had 2 expanders in, and she gave her son a hug, and her son said to her, "Oh my God, Mum, they feel like door stoppers." And they do feel pretty rock hard. But other than that, there's no problem with having the expanders inside you until you get to the volume you want, and then you can just exchange the expander for an implant. I've had 2 patients who both had cruises booked a couple of months away, and they were both very keen to try to get the whole thing done before they went on the cruise, and neither of them succeeded, but they just went on their cruise with their expander, and then when they came back, we finished the expansion, we put in the implant. So you can still do everything you want to do with an expander, but it's just that it doesn't look as good or feel as good as the extended implant.
Yeah, so probably the most important takeaway from that is don't rush it, because it'll just naturally be at the right time for you.
There is no rush, and the key thing is you don't want to have any more discomfort and pain during the expansion process than what you have to.
Yeah. Okay. And so is there any special preparation for the breast reconstruction that the patient can actually do? Like, I know about your tissue expanders, but what else might a breast reconstruction patient need to consider during the weeks or months leading up to, or during the process even? Yeah.
Well, look, obviously for patients who are having an immediate reconstruction, that means they've got a diagnosis of cancer. Many of them have only just been diagnosed with their cancer, and they're in a terrible kind of situation from a psychological point of view, from a family point of view. I think it's very important to make sure that you're comfortable with all the information you're being given by all the members of the treatment team. I always encourage patients to come along with their partner, with their family, and to come along and see me as many times as they need to before the surgery, to make sure that all their questions are answered. It's a time of, you can understand, great concern, great fear, great worry. So it's important that patients understand what their options are, because there are options. And so I'll just put that up there. And it's also important that they understand the journey which they're about to go through. In terms of patients who are having an elective reconstruction, so say, for example, they've had a mastectomy a year or 2 before, and now they've decided they're going to go through a reconstruction, the most important thing is to be as healthy as you can. And the most important thing in terms of being healthy is not smoking. Smoking is the worst thing you can do in terms of any form of reconstructive surgery in general, and breast reconstruction in particular. I see patients who even having an immediate reconstruction, and they may be an active smoker, and the big message is they just need to give up. I always say to them, look, go downstairs, have one last cigarette, and then that's it. Give me as many weeks as you can before the surgery. And the reason why smoking is so important to be ceased is because it affects the blood flow to the skin. And when we're doing our surgery, especially if we're putting an implant in, there may be a bit of tension on the skin. And so you want the skin to have a good blood supply. Otherwise, the skin edges can die back. That's called mastectomy flap necrosis. If that happens, we may need to go back and then take out the dead skin. And if we take out the dead skin, we might not be able to close the dead skin over the implant. So we may have to take the implant out and maybe put an expander in, or take the implant out and leave the implant out. But in terms of patients who are smoking, every complication you can think of, whether it's wound healing problems, bleeding, or infection, are increased in patients who smoke. So certainly being healthy is very important. In terms of delayed reconstruction, and now we're kind of getting along to other forms of breast reconstruction, whenever I can, I like to use the patient's own tissue to reconstruct a breast. The most common tissue we use is skin, fat, and muscle from the lower abdomen. And so essentially you give the patient a tummy tuck, but instead of throwing that tummy tuck tissue away, you use that tummy tuck tissue to reconstruct a breast. You remove the tummy tuck tissue, with an artery which takes blood to the tissue and a vein that takes blood away from the tissue. You find an artery and a vein up here on the chest wall. You join the artery to the artery and the vein to the vein, and you re-establish the circulation of that tissue up on the chest wall.
Okay.
And so that is called a free flap. A flap just means tissue which is isolated on blood supply. A free flap is actually, it's free. It's out of the body, and then you're putting back where you want it to be. Where that tissue came from, which is the lower part of the tummy, you just close that as you would a normal tummy tuck. So, you know, it's a scar from side to side with a new hole for the belly button. But as you can imagine, if someone has had a mastectomy or even a double mastectomy, a bilateral mastectomy, and you are able to then reconstruct both breasts using the skin and fat of the lower abdomen and give them a tummy tuck at the same time, the results are incredibly dramatic, and it completely changes their body shape. And I've got to say, for most of them, it really changes their outlook. As you can imagine, it's incredibly confronting for someone to have one mastectomy, let alone two mastectomies, and to be able to perform a reconstruction where we can replace what has been removed in treating the cancer is something that that patients find and surgeons find very rewarding. So that procedure, doing a tram flap or a DF flap, which is where you leave the muscle behind, or a muscle sparing tram flap, they're all pretty similar. You're just taking the tummy tuck tissue. But that kind of operation, it's a longer operation. It's a safe operation. Surgery we do all the time.
Yeah.
There are potential risks and complications. But I do want patients to be as healthy as they can. Yep. Patients often say to me, "Oh no, but if I lose weight, you won't have enough." No, that's not true. There's normally more than enough.
Always some fat to get from somewhere.
Yes. And so the key thing is approaching this kind of surgery, just get as healthy as you can.
Mm-hmm. All right. And so do you do any like fat transfer at all in that process? Like, is that?
Yeah, in terms of fat grafting, I think most surgeons who do breast reconstruction do small amounts of fat grafting after you've done the main reconstruction, whether it's with an implant or some sort of flap. Might use small amounts of fat graft, which is where you harvest some fat elsewhere, either from the buttocks or the thighs or the lower abdomen. You kind of prepare the fat in some way. I normally just sort of filter it until I get purified fat. Then you can inject that fat onto the chest wall. There are actually certain places around the world where they're actually trying to do the whole reconstruction just using fat grafting. That is something that hasn't been widely embraced in Australia, mainly because there are some, at least theoretical concerns about possible promotion of cancer. Mm-hmm. Fat grafting contains growth factors and the like. And in the laboratory, it's been shown that the kind of growth factors you can get with fat grafting can actually promote the growth of cancer cells in general. So for that reason, in Australia, as a group, everyone's sort of held back a little bit in terms of doing massive fat grafting, just to make sure that there isn't going to be any sort of issues with patients developing further cancer down the track, or even just developing things like cysts or lumps as a result of the fat grafting, which would be extremely distressing and which then need to be differentiated from a cancer. But certainly, fat grafting is something that most of us do use to a small degree as an adjunct. Like say, you do your reconstruction, there's a little area which is flatter, or one side's still a little bit smaller than the other. We might use relatively small amounts of fat grafting just to improve symmetry and the overall shape.
Yep. And I think as a nation, we are pretty conservative with stuff like that. It's better to err on the side of caution, I think, when it's not.
Yeah, it is. Look,
I'd feel comfortable if it was me. I'd want them to be more conservative than...
Yeah, no, without a doubt. I mean, I keep my eye on what's in the literature pretty carefully. And certainly there's a big group in Miami who've been using fat grafting for breast reconstruction for quite a few years. They've had all their patients had MRIs. They haven't reported any increased incidence of breast cancer at this stage. Mm-hmm. So that's certainly something that may become more common in Australia in future years. But at the moment, it's something that we're sort of holding back a little bit.
Yep. All right.
Yeah.
And if a patient has, I only lost one breast and only need reconstruction on one side.
Yeah.
How often do you also need to maybe adjust the other breast in order for them to be balanced, or do you just try and fix the reconstructed breast to be more like the existing one?
Yeah, look, it all depends. The questions which I ask patients who are coming for a reconstruction is, are you happy with the shape and size of the other breast?
Yeah.
Okay, because the whole idea is symmetry. But the other thing to say, Trish, is that different patients have different aesthetic demands, or cosmetic demands, okay? So there are some patients who say, look, you know, it doesn't have to look exactly the same as the other breast, just as long as the volume's the same, so I don't have to put something inside my bra. So when I'm wearing a bra and I'm going out or I'm at the beach, you know, I don't have to worry about, you know, the chicken filler, you know, the kind of implant that patients put in the bra to make them symmetrically clothed. So some patients have a very low aesthetic demand, and so all they might want is just something with volume, which is vaguely like the other side. Whereas other patients have a very high aesthetic demand, where they want to look as close as they can when they're naked from one side to the other. So that's talking about nipple reconstruction, nipple tattooing, trying to get the shape and size as good as we can. So the first thing as a reconstructive surgeon is to ascertain what the final goal is of the patient, and then have a look at them and then have a frank discussion about where I think I can get them, just so that their expectations marry with what hopefully my surgical ability is. In terms of the other breast, if a patient has a breast which is very youthful and there's no drooping or ptosis or whatever, then that might make it easy. Then we can just say, look, you've got a great looking breast on the other side, we'll just try and match that. If the other breast is very broad and large and very drooping, then we might say, look, why don't we look to do a breast lift or a breast reduction on the other side, and then try to match that on the reconstructed side. As a general rule, and then there are some patients who say, look, I've actually always wanted to be larger than what I was before, so we'll put an implant on one side, and then we can do an implant-based breast reconstruction on the other. As a general rule, what I explain to patients is that it's easier to match a breast reconstruction with an implant with the other side if it also has an implant. If the other side doesn't have an implant, then often you'll get better symmetry because it's their own natural tissue, it's using the patient's own natural tissue. So that's kind of the way I approach it overall. So if someone has a very natural breast with a natural sag on the other side, even if it's not so bad that they need a lift or whatever, generally I find you'll get much better symmetry by using their own tissue, by either using a DF flap, a tram flap, or some other flap using their own tissue. But the end result of this sort of part of our conversation is the goal is symmetry, and it's just important to work out from the patient what level of symmetry they're after.
Yep, okay. Because in the case of, what's her name? The most gorgeous woman in the world, Angelina Jolie. Yeah.
Yes, so she had a bilateral.
Yeah, so she had tissue removed from both breasts and replaced with implants.
Exactly, yes. So the idea is symmetry. And in fact, I have many patients who come to see me with a breast cancer on one side, and they've come along to see me to have one side replaced. But then during our consultation, I'll show them before and after photos and actually say, you know what, I don't want to have a mammogram every year for the rest of my life, because I know I'll just be nervous, you know, leading up to the mammogram, and then, you know, waiting for the next mammogram, you know, sort of drumming my fingers thinking, oh my goodness, you know, my next mammogram is 10 months away, is it going to be okay? And many patients will actually opt for a bilateral mastectomy and a simultaneous reconstruction, because then I can be more confident about giving them a symmetrical result. So they're not removing the other one for a cancer reason. They're removing the other one prophylactically, so it can never develop a cancer. But it also means that I can be more confident in giving them a symmetrical result.
Okay. And in that case where you're doing both at once, is that something that you do, or do you need the breast, like because I know that it's a team, but is that something that you can do?
No. I have the breast surgeons I work with do the mastectomy side of things, and the reconstruction side of things.
Got it.
Yeah.
All right, great.
So, but obviously we work very closely together. And you've got to make sure you've got a good relationship with your breast surgeons.
Yeah.
And there are times when they will say to me, look, I know you're thinking of doing a tram flap for this patient here, but, I think she's got a very high chance of needing radiotherapy. You might want to hold off on the tram, just in case the tram gets shriveled by the radiotherapy, and you're better off doing it after the radiotherapy, for example. So we'll often have a bit of a conference call before our cases, just to make sure that we're agreed on what their plan is and what my plan is. Sometimes the patients will insist on a nipple sparing mastectomy, for example, where the nipple is preserved, and the breast surgeons I work with might have me, for example, help them design the incisions that they're going to use, just to make sure that I can comfortably complete my surgery and have the access that I need for whatever I'm doing.
Okay, so that leads to the next question. So obviously with a breast reconstruction, nipple may also need to be created. So how does that work? And would the patient ever have sensation in that nipple at all? Or
No. Yeah. Unfortunately, with most breast reconstruction, they remain numb. They remain insensate. In terms of reconstructing a nipple, so as we said, sometimes we can actually spare the nipple, which is great. That gives you a really good cosmetic result. We actually spare the nipple, but breast cancers are normally ductal cancers, where they start in the ducts. All the ducts empty onto the nipple, and so in many cases the nipple needs to be removed just to make sure the cancer's gone. And remember, that is the most important thing. We get rid of the cancer and treat it appropriately. But if the breast surgeons are confident that the cancer can be treated and preserve the nipple, then we'll try and preserve the nipple. If the nipple needs to be removed, which does need to happen quite often, then there are ways of reconstructing a nipple. The most basic way, you can actually get a stick-on nipple. They make little adhesive nipples, which you can...
Oh, I've seen them. They look amazing. Yeah,
they do look amazing, but they're a bit of a hassle. You've got to take them on and take them off. Not there all the time and all that kind of stuff. But many patients of mine sort of transition through that stage while they're sort of deciding whether they're going to go for a nipple reconstruction or not. They might try using it and then sort of think, oh, look, I do like having a nipple. I don't like one that I have to take on and off. So, yes, I'll have surgery in order to reconstruct a nipple. Okay. So a stick-on nipple is one option. The next option is a tattoo. You can just get a simple tattoo. They call it a 3D tattoo because they can sort of give the appearance of a shadow of the actual papule, the prominent part of the nipple itself. So just in terms of what we're talking about the areola, which is the circular area, and then you've got the nipple itself, which is the papule in the middle. So you can have a tattoo of the areola, which gives a shadow effect, give the idea that the patient has a nipple. In terms of surgery, what we can do, we can actually fold skin on itself in order to create the prominence of a nipple. We may need to do a skin graft, or sometimes we can just sew the skin back together again around it, and then we let that settle down, and then that nipple that we've created can then have a tattoo a couple of months down the track, normally 3 to 6 months down the track. And that gives you the absolute best cosmetic result because you actually have the prominence of a nipple, the shape of a nipple, and the colour of an areola. And that really is the gold standard. So in terms of when patients come to me, because some patients do, they come to me and say, look, I just want to have the best. What is considered to be the best reconstruction? In terms of what would be considered our gold standard, it would be using the patient's own tissue with a nipple reconstruction that is then tattooed. And that would be the gold standard reconstruction. But not everyone wants to have that kind of degree of surgery. Many patients get an excellent result with an implant. Even with an implant, for the vast majority of patients, you can still construct a nipple. Some patients who, say, had radiotherapy after they've had an implant and all the tissues are a bit thin, it might not be safe to try to raise some skin on top of the implant in case it gets infected or exposed, for example. But other than that situation, the overwhelming majority of patients are suitable for a nipple reconstruction.
Okay. I've actually seen some of the most amazing nipple tattoos. Like what they can do there is amazing.
Yes, it really is. It really is.
All right. So I've got one last question here. So breast reconstruction, obviously, it's got the potential to be a more emotional journey than other plastic surgery because of the reasons behind it.
Yes.
Do you find that these patients and their journeys are more emotional than other types of plastic surgeries?
Oh, yeah, no, without a doubt. I mean, you're dealing with a number of issues. I mean, not just dealing with cancer and the thought of ill health the thought of mortality, the thought of death one day. Also, you're dealing with family. The majority of patients tend to be between the ages of 40 and 70. The majority are wives and mothers, and so they've got their family who they tend to be the main carer for. So there's not only concerns for their own health, but look, what's my family going to do while I'm having chemotherapy and radiotherapy, and my husband can't even find his socks and all this kind of stuff. So there's those sorts of very practical fears that patients have, just outside the fear of, my goodness, I've got a cancer, which, is a leading killer, and I've got to go through surgery and, often chemotherapy and radiotherapy. So that does add an element of emotion. In terms of one's self-identity, your identity as a woman is extremely important. And to lose a breast or two breasts is devastating. If you think about a male who had to be castrated, it's the same thing. It's a potentially devastating surgical procedure from that point of view. And that is why reconstruction is actually very important for these patients. That's why reconstructive surgery is paid for by the health funds. It's covered by Medicare. You can have it done in a public hospital because it's recognised as being an important part of the treatment for that reason. And so as you quite rightly say, it's probably unique amongst the kind of reconstructive plastic surgery procedures you perform. It's one where you get to know the patients very well, and you really have to get to know the patients very well, just in order to understand where they're coming from, and you work with the patients in order to work out a plan, what's going to be best for them at what time, in what way, and all those sorts of issues. But the final thing I say is that it can actually be probably the most rewarding part of my practice, even though it's not the easiest part of my practice by any means, but it's a very rewarding thing to hopefully be of use and helpful in that particular time of someone's life.
Yeah, no, it's so good. I love that. I know that you're really passionate about it, and I love the fact that you're so empathetic about it as well. And I really appreciate your time today. That's been so helpful for people as well. So so ladies, ladies, it's only ladies. Actually, no, I do know a man that had breast cancer. But
yes. They say 1 to 2%, but obviously they don't need a reconstruction. But
no.
Yes.
Yeah. Or if you're in Sydney, Dr Damian Marucci, he practices at Cogra, and he's available to help you. So thank you so much, Dr Marucci. Thank you so much for taking
No worries
today. All right, thank you. Bye.
Yeah, thanks.